Uh, Thank you very much for taking my views. And my views are little radical because what has been happening over last decade, the India's contribution to ART, antiretroviral treatment globally, has been 80% almost 10 years back. Currently, it is 92% or more than 92%. That means that whatever number of people, whether there are 20 million or 22 million people who are taking ART, 92% people who are people living with HIV, they are taking ART made in India, made by Indian pharma companies, generic ARVs. And therefore, today, if the people in Africa and many lower and middle income countries, if they are alive, who are living with HIV and they are alive, that is thanks to India and Indian pharma companies. Whatever all these big organizations, including World Health Organization, UNAIDS, Global Fund, World Bank, or any bilateral, multilateral agencies, Gates Foundation, PEPFAR, whenever they declare any program in last 10 years, that is on the strength of India. What I'm saying is that if they talk about prevention, treatment as prevention, or TASP, or test and treat, or treat all, or post-exposure prophylaxis, pre-exposure prophylaxis. When they're talking about this, if they talk about their 8 or 10% of population of people living with HIV in their countries, that's fine. But when they're talking about globe, that means 92% of the global people living with HIV or those who are at risk of HIV and taking PEP or PrEP, they are taking medicines made in India. But all these agencies, they shy to take name of India whenever they talk about that. I don't know why. That can be because of one-upmanship, that we are the people, we are making the drug, we are the patent owners, we are the rich countries, and we can suppress and oppress the lower and middle income countries. That is one. Second thing is jealousy. Uh, by and large, people don't want to take India's name in a good sense anytime, particularly from the Western countries. And we feel bad. Today, if you take any African country, any poor or lower income country, you go there, not only HIV, whether you talk about any infection like tuberculosis, other infectious diseases, antibiotics that they are consuming, they're all made in India. Now, I will go one step beyond that. If you talk about even the patent owner companies, you see all their products. Not all the products are made in their country. They are all, many of them are manufactured in India. They just may be labeling as XYZ company, but they are manufactured in India, and that is mentioned on their products also. So, for their own people who can afford and who can pay the cost of innovator companies, fine. But for those people which are from the lower and middle income countries, they cannot bear the cost what is decided by them. For example, the cost of the pre-exposure prophylaxis, lenacapavir, is 28,128 dollars, $28,128 per patient per year. How many people, even in their own country, can afford that? It's okay, you earn, you spend. But for our countries, India included, we need Indian pharma companies to subsidize or to produce at such a low cost, which is accessible and affordable. And there is only one country in the world which can do that, is India. Though the innovator company Gilead may have given license to 6 companies, 4 are from India, 1 is from Pakistan, and 1 is from Egypt. And I don't think this will be ever produced in Egypt and Pakistan anytime. So ultimately, it is produced in India. If we are going to provide, and at what cost? We are looking at a benchmark cost of $100 against $28,128. So this is going to happen in next year, maybe a couple of months or so. But if you go to past, hepatitis C medicine, HCV medicine, HCV cure was also found by Gilead. Their cost was $1,000 per day, $84,000 for 84 days course. And when they realized that India can copy that. Either India can get a compulsory license from our government, or they just forgo patent and manufacture by different means and different ways. They automatically came to India and they gave a license to 11 companies. And they told the companies that $84,000 worth medicine you should produce in your Indian companies and sell it for $1,000. So on their own volition, they come down to 1% of international cost, 1% of their cost. However, the 12th company came from India, and that company said, why you choose and how you chose only 11? Why not me? And we'll defy your voluntary license also, we'll produce. Let us see what we can do. And that company produced, and that brought down the cost from $1,000 to $300. Today, hepatitis C cure is available from 11 plus 1, 12 companies from India at around $250 to $300. So can you imagine, this is 0.3% of global cost. Same thing with ARV, the quoted cost of per year 3-drug combination, when it was decided around 2005 or so, it was $10,452 per patient per year. And the lowest Indian quoted cost today is $69. So it is 0.6%, 0.7% of the international cost. And therefore, if you are using Indian medicine for your programs, you are glorifying yourself that we have done this, we have done that, we have this guideline. Your all guidelines are based on the strength of India. Why don't you say that it is because of India? I was recently in Japan. Because of the problem with the Trump administration, they are not going to fund PEPFAR. They stop funding of NIH. Some other rich countries are going to take up. This issue was to be taken up by Japan government. And they were discussing in Japan, the parliament is called Diet Committee or National Diet Committee. On the National Diet Committee, when they're discussing about this, that Japan should take over the funding for the lower and middle income countries. The 2-page document, not one word on India. And I suggested them that why don't you say that this generic medicine orchestrated by India or made in India. They refuse to put that. So I think it is ridiculous that you don't want to say a spade is a spade. You don't want to give a little credit to a country which is responsible for making this medicine at 0.3 to 0.7% of international cost, making it accessible and within time-bound period. We have shown during COVID, we have shown during tuberculosis, we have shown during a lot of other infectious diseases that India has a capacity to, and earlier there used to be a saying that cheap medicines are bad medicine. I remember about 15 years before, one international company people came from USA. They came to my clinic. They visited a delegation of about 8-10 people. And they looked at some medicine made by an Indian pharma company. And they said, Dr. Gilada, can we take this bottle? I said, you pay the cost and take the bottle. After they took the bottle, for 1.5 years, 2 years, there was no noise, no voice, no publication, there's nothing. So at one of the international conference, I asked that company, I said, you have taken that bottle from my clinic. I did not see that bottle in any museum anywhere in the world. Where is that bottle? That means you took the bottle, you took it to your lab, you analyze. When you analyze, you found that it is bioequivalence or purity or everything was same as compared to your innovator medicine. And therefore you kept quiet. You don't dare to even say that Indian medicine made at 0.3% cost has 100% bioequivalence to our innovators' medicine. So this is the dichotomy, dilemma. This is the double standard of the world, and we need to stop this. Today, I have extensively traveled in Africa between 2000 to 2005, made at least 80 to 90 trips to educate doctors, to train them that you, being even Africa, can manage HIV. And I said, we are a South-South collaboration. If we can manage in India, why can't you manage? But those Western country people who use Africa as their experimental lab, they did not allow the medical doctors from Africa to be doctors. They say, okay, you don't have CD4, you don't have viral load, you don't have ARV, so you are meant to die. That was the scenario created there, and we changed that scenario. I traveled to Kenya, Uganda, Burundi, um, DRC Congo, Brazza Congo, Angola, South Africa, Botswana, and all these countries we trained doctors. Then we introduced them to Indian ARVs. Some of them were buying, particularly in Angola. When I went to the pharmacy, I seen a medicine made from one of the Indian pharma companies. I don't want to take their name because I'm not representing any company. I'm representing my country. So I told those people that look, this bottle is from India. No, 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 it is coming from Brazil. I said no. Hyderabad is in India. It is not in Brazil. And then following that, a delegation from Angola, led by the health minister of Angola, they visited us. They visited my clinic to see that. They visited the pharma companies to see how they are manufacture medicine, and then they started buying directly from India. The difference was what they were buying for $3, they were getting at $1 from India. So if medicine was going from Hyderabad to Delhi, Delhi to Brazil, Brazil to Angola, it was costing them 3 times more. They realized that this is not the system of buying. And more so, now most of the medicines which are manufactured in India and supplied to Africa or any LMIC, they are manufactured in a GMP, Good Manufacturing Practice Units, WHO pre-qualified units, PEPFAR or USFDA pre-qualified units. That means our medicines are no way standard, substandard. Secondly, even earlier they used to think of packaging. That look, our packaging of a multinational company is so. Now you compare even packaging. You compare anything. You compare content, purity, bioequivalence, packaging, and then you compare the cost. So everything is similar to you, but the cost is 0.3%, 0.7%, 1%, and newest medicine can be at 2 to 3% of the cost. So I think it is a good South-South collaboration. Africans should not feel that they are left out. We, India, as a country, we are standing like a rock behind you. Even in the difficult situation, when the PEPFAR is not going to fund you, we'll see what best can be done. There could be other ways and means. Like example, now many people can be treated with 2 medicines rather than 3 drug combination. So tenofovir can be taken away. So if one molecule is taken away, the cost can go down. Dolutegravir, which is almost 90-95% people in the globe who are PLHIV are taking DTG-based regimen. DTG was tried in 10 milligram, 25 milligram, 50 milligram. The reports or the study research finding were similar to 25 milligram and 50 milligram. Just for 2 or 3 cases where they got some resistance, it was preferred to have 50 milligram. So now we can look back. We can make it 25 milligram, it will work. And we have seen that and shown that and established that if our is 600, now 400. AZT or Zidovudin 600, now 400. D4T, which was 40 milligram, became 30 milligram. DDI, which was 400 milligram, became 250 milligram. Indinavir, which was 2 tablets 3 times a day, became 1 tablet, 1 capsule 3 times a day. So we have demonstrated that earlier benchmark, which was established as a high milligram molecule or high dose molecule, that can be reduced after due years of practice, after research. But this research cannot be done and will not be done by pharma companies. This research has to be done by foundations. And like TLE 600 to 400, that was supported by Bill Gates Foundation. So some of the such kind of research has to be a kind of a non-profit organization-based research, some foundation-based research, then it will succeed. And lastly, we should not depend 100% on a subsidy. We should not depend 100% on donation. So there has to be some co-payment, maybe 10%, maybe 15%. So even Africans should also inculcate that habit of contributing 10%, 90% coming as a donation. Fine, it will work. And that is an example of India where for last 15 years, we are not donor dependent. We requested government that a country like India doesn't need donation from other rich countries. There are many, many poor countries. The country size of that of Mumbai or country size that of one of the states. And they, if 10, 15, 20 countries can be benefited on one hand, and if India gets that pie on the other hand, it's better that those countries benefited. And good that our government has made entire program self-reliant. And that's the reason that as soon as Trump administration declared cease on funding on PEPFAR or NIH, India was not affected. Maybe 2-3% programs, some programs are affected where some Indian programs were not reaching and they were dependent on PEPFAR fund. But largely, 95% of the program is not affected. And therefore, we need to make it self-reliant program, and that should be the theme for this international conference.